Hello everyone. Today we will explore one of the essential components of vital sign monitoring, the pulse. Understanding pulse is foundation for clinical practice as it reflects cardiovascular function and can provide crucial insights into patients' health status. Our session today will follow this structure. We will begin with an introduction to the pulse and its physiological basis. Then we will cover the factors influencing pulse, the anatomical sites for assessing pulse, the technique of pulse measurement, and the various characteristics you must assess. By the end, you should have a thorough understanding of how and why to assess the pulse in a clinical setting. Pulse is one of the four traditional vital signs, along with blood pressure, respiratory rate, and body temperature. And nowadays, pain is often considered the fifth vital sign. These signs, when looked at together, help monitor a patient's vital functions and detect early signs of deterioration. Remember, interpretation must always consider the patient's baseline values and overall health context. This slide gives you an idea on how often and when you should assess vital signs. Now, since we are done with the introduction, let's dive in. What is pulse? The pulse is a palpable wave of blood flow generated by the contraction of left ventricle. It represents the stroke volume, that is, the amount of blood ejected with each heartbeat. Factors like arterial compliance, that is, how well arteries expand and contract, affect the quality of pulse. When a person's arteries lose their elasticity, as can happen in old age, greater pressure is required to pump the blood into the arteries. Cardiac output, calculated as stroke volume multiplied by heart rates, is central to understanding pulse. For example, 65 ml per beat into 70 beats per minute gives a cardiac output of around 4.5 liters per minute. A healthy adult heart typically pumps around 5 liters of blood every minute at rest. In healthy individual, the pulse is indicative of the heartbeat. That means the pulse rate is equal to heart rate. We may classify pulses based on their location. First, the peripheral pulse is a pulse located away from the heart, for example, in the foot or in the hand. The apical pulse is the central pulse located at the heart's apex and is assessed using a stethoscope. The apical pulse is sometimes also called the point of maximal impulse. Peripheral pulses, such as the radial or dorsalis pulses, are usually palpated using our fingers. We usually express pulse as beats per minute. Many factors can influence pulse rate and quality, like age, gender, exercise, fever, certain medications, hypovolemia, and stress. For example, pulse increases with fever due to vasodilation and higher metabolic demand. Understanding this helps us interpret deviations appropriately. Sudden changes in position can also lead to alteration of pulse rate. Pooling of blood results in a graduated decrease in venous return, which leads to a reduction in blood pressure, and to compensate for that reduction in blood pressure, the heart rate increases. Also, certain pathological conditions can result in altering the pulse rate. Pulse can be assessed at multiple sites. Different pulse sites provide different clinical information. Radial pulse is the most common site where we palpate pulse. Carotid is preferred mostly in emergencies. Dorsalis pedis and posterior tibial pulses assess peripheral circulation, especially in diabetic patients or patients with vascular diseases. How to assess pulse? The pulse is commonly assessed by either by palpation or by auscultation. Like we discussed earlier, all the peripheral pulses are assessed by palpation. We have to use the middle three fingers to palpate peripheral pulses. For the apical pulse, auscultation with a stethoscope is necessary. We should avoid using our thumb because it may lead to a false interpretation. You should take your time while assessing the pulse because you have to observe and record key characteristics like rate, rhythm, volume, arterial wall elasticity, and bilateral equality. Each one of these provides insight into the cardiovascular function and overall perfusion. A normal pulse rate is between 60 to 100 beats per minute. A pulse rate greater than 100 beats per minute is known as tachycardia, and below 60 beats per minute is known as bradycardia. Rate alone doesn't tell you the full story. We must correlate it with other characteristics and clinical context. There are multiple reasons of tachycardia, which are listed below. The various reasons due to which the heart rate can be below 60 are listed here. Pulse rhythm tells us about the regularity of the beats. A normal rhythm is regular, whereas an abnormal rhythm can be occasionally irregular, regularly irregular, or irregularly irregular. Each of these abnormal pulses can be characteristics of specific heart conditions. Rhythm is inconsistent. Pulse volume reflects the strength of pulse wave. A high volume pulse may result from conditions like aortic regurgitation or fever, while a low volume pulse could indicate hypovolemia or heart failure. Sometimes volume may vary from beat to beat, as seen in arrhythmias. Now let's discuss about the condition of arterial wall. In older adults, stiff arteries, often due to atherosclerosis, can alter pulse quality and increase systolic blood pressure. How do you assess condition of the arterial wall? You try to roll your fingers over the artery. Now, if you can roll and feel the artery and it feels cord-like, then the condition of arterial wall, the elasticity rather of the arterial wall is lost and it has become stiff. Usually, the arteries are soft, and if you roll your fingers over the artery while you can feel the pulse, you won't be able to feel anything. You won't be able to roll your fingers over the artery. Now let's look at some special pulse patterns that help diagnose many conditions. First, we will discuss collapsing pulse. Second, we will discuss slow rising pulse, then pulsus bispherians and pulsus bigeminus, pulsus alternans, pulsus paradoxus, anacrotic pulse, and finally diacrotic pulse. Collapsing pulse, also known as water hammer pulse, is a sharp rise, ill-sustained, sharp fall, and wide pulse pressure. High volume collapsing pulse is seen as aortic regurgitation and PDA, that is patent ductus arteriosus. Normal volume collapsing pulse is a feature of mitral regurgitation. Slow rising pulse is seen in severe aortic stenosis. There is a gradual upstroke with a reduced peak, as you can see in the figure, and the peak reaches late in the systole. Pulsus bispherians, which is seen in aortic regurgitation and concomitant aortic stenosis and regurgitation, is characterized by a double systolic peak, which is separated by a distinct mid-systolic dip. Pulsus bigeminus is a regular alteration of pulse pressure amplitude. It is mainly caused by premature ventricular contraction that follows each regular beat. It is seen mostly in AV blocks and sinoatrial block with ventricular escape rhythms. Pulsus alternans, rather, sorry, pulsus alternans is a very rare condition where there is a beat to beat variation in pulse volume with a normal rhythm. It occurs mostly in advanced heart failure, toxic myocarditis, and paroxysmal tachycardias. Pulsus paradoxus is an exaggeration of the normal variability of pulse volume with breathing, or you can also say abnormally large decrease in systolic blood pressure during inspiration. It is characterized by a drop in blood pressure of more than 10 millimeter of mercury when a person inhales. During inspiration, the diaphragm contracts and the chest cavity expands, creating negative pressure. This negative pressure normally helps draw blood back into the heart. However, in conditions that affect the heart or lung function, these pressure changes can exaggerate the drop in blood pressure. Recognizing pulsus paradoxus can be important for diagnosis and treatment. It can help identify conditions like cardiac tamponade, constrictive pericarditis, and pericardial effusion, which may require urgent intervention. As you can see in this figure, pulsus paradoxus is an exaggerated version of normal slight decrease in blood pressure, which occurs during inspiration. This normal decline is usually imperceptible, but in cases of pulsus paradoxus, This difference in pressure is greater than 10 millimeter of mercury. Anacrotic pulse is seen in aortic stenosis. It is characterized by a slow rising double beating pulse, and both waves are felt in systole. Diacrotic pulse, it is also twice beating, but the first wave is in systole and the second wave is in diastole. It is mainly felt due to the hypotonia of the vessel wall. That is, the tone of vessel wall is reduced. It is seen in fever like typhoid fever, congestive cardiac failure, and cardiac tamponade. Now, coming to radiofemoral delay. This clinical sign suggests delayed or absent femoral pulse compared to the radial. That means you have to palpate both the pulses simultaneously. It is commonly associated with coarctation of aorta, especially in young patients, and must prompt further cardiovascular evaluation. Just radiofemoral delay doesn't diagnose it, but it gives you a hint where your further investigation should proceed, in which direction. The other causes which might cause coarctation of aorta are atherosclerosis of aorta and thrombosis or embolism of the aorta. Both of these causes narrowing, so there might be a radiofemoral delay. Absence or asymmetry in peripheral pulses may signal vascular pathology like peripheral vascular disease, Takayasu arteritis, or aortic conditions like coarctation of aorta. Always compare both sides when examining peripheral pulses. Thank you for your attention. I hope this session has clarified the fundamental and clinical importance of pulse examination. Remember, mastering vital signs is a vital step in becoming a competent healthcare professional. Thank you. See you again in the next session.